Okay, I'm going to go ahead, 2 talks that I wanted to do. So I'm going to go rather quickly through this. I didn't get this finished until 6 a.m. this morning, so you will get this electronically. So sit back. You really probably don't have to take notes because you'll get this whole PowerPoint. One of these is a completely new concept, and the other one is y'all have heard me talk about Pap smear screening for eternity. So I'm going to go through those slides pretty quickly, but certainly the group at Women's Health are happy to go over anything. I try to, since it's such a broad range of people, we've got newbies out there who are just now doing cervical cancer screening, and then we've got people who've been doing it for years. So my background is OBGYN, so women's health is obviously so very important to me. So appreciate you being here. We're going to start out today with something some of you have heard of. I know at the APRN meeting we talked about this. I think it was this last year in Bardstown, but the ACEs. ACEs stands for Adverse Childhood Experiences. If you've not heard of this, you are going to, because it is, we think, going to revolutionize how we take care of people with chronic illness. So I've got a picture of 3 babies. All I know about babies is the 5-minute Apgar, and then you give them to somebody. But now I have a 1-month-old grandchild, so I'm more into this size babies now than the 5-minute Apgar baby. This, if you again have not seen this before, this is the life course perspective. When I first saw this slide, when I saw Dr. Ruth Ann Shepard give this slide, I thought, well, that's not a real slide. It's not science. There's no data points. How can you have a slide with no data points? And then I really looked at it. And this is from Dr. Michael Liu, where they showed that our outcomes and our lives are determined by not only what happens to us early in our lives, but if you look at that line, it doesn't start at 0 years. It starts before birth. And so you've got a white middle-class gal here up on the top line. Her pregnancy is good. She starts out good. She goes through age 5 years. Puberty, things start happening to her. She goes to pregnancy. I like the way pregnancy brings things down. Again, 20 years of OB, I understand that. But this woman is on a good course. What you have on the bottom dotted line is a 14-year-old that gets pregnant. Pregnancy is not good, possibly because she didn't tell anybody she was pregnant. And then you see that by the time she gets to pregnancy, she is in a very, very different place than her counterpart on the top line. I think that's when it resonated with me, because as an obstetrician, I did everything I could possibly do to make pregnancies good, and they didn't come out good. And that's because I was starting in a different place. And when I show this slide and explain this to a room of OB doctors, literally some of them are in tears, because it helps them to understand that if I do the same thing for everybody, I'm not going to get the same outcome because everybody's not starting at the same place. I wish I'd done this slide in color because you see these arrows pushing down on those that life course perspective. Those are the risk factors. Those are the bad things that can happen in a lifetime that can push us down. And we in public health have spent most of our lives trying to fix those things. What we're finding out and what we're learning from the ACEs studies, that those protective factors, those up arrows, everybody listening to me is an up arrow for our patients. Those are the things that counterbalance. You can't fix the poverty in your community. You can't fix the unemployment in your community. But you can be an up arrow that might help this kid graduate from high school, that might help this kid have some self-esteem and actually take themselves to the next level. We're going to talk about resilience real quickly. So burn that image in your mind. You're going to see it because, like I said, I'm going to go through these quickly, but you will have these to peruse and look at later. The most important thing to remember is the brain is not mature at birth. Well, that's kind of a duh. I think we all know that. We definitely know a brain is not mature in adolescence. I did have a 15-year-old stepdaughter when I married my husband. So we know that things happen to the brain, but what we don't really realize is those first few years are those critical periods where you're having the brain hardwired. And if you think about it, I'm going to show you a picture in a minute of the brain. All the neurons aren't there. All the synapses aren't there. Everything's not there. And those experiences before age 3 will impact those capabilities of that brain to function. Lots of other stuff. So the picture, which to me, I'm very visual, the picture on the left at birth, that shows a brain biopsy. Didn't ask anybody where they got these, but that's a brain biopsy at birth. And that shows that you've got neurons and synapses and all of that kind of stuff. Look at what happens by 6 years. Tons and tons of things have grown. If that baby's not stimulated, that growth does not happen. And then if you look at 14 years, actually the brain goes in and prunes things that aren't really connected to anything and said, you really don't need this. So you grow brain cells or neurons. You get rid of some that you don't need. And our goal is to get as many of those synapses as possible. Your success in life is as much related to your vocabulary at age 3 as it is to your graduation from high school. Think about that. How many of the kids that we see that come through our health department, or how many of the patients we see in our health department, can we just mentally imagine where they were at age 3 and what was happening in their lives? So this just is a nice slide that shows how the brain develops. We do sensory. First the baby, we took care of my grandbaby last week, and then we took care of her last night, and she's already starting to look at things. Now, I don't think she knows those fingers are hers, but she noticed something was happening, whereas last week she didn't notice that. It's amazing what happens in a week. Then we have those language skills development, and that's what we talked about, age 3, how critical that is. What do we do now in health departments that the age 2 and age 3 are very important? Hands and first steps. So we've designed programs around this, I think, before anybody ever pieced all that physiology together. So I love this picture, love this picture. This is called serve and receive, just like in tennis. The mama serves something, the baby reacts to that. So those birth to 2 are those critical windows for the hardwiring of the brain, which is where social emotional attachment happens, and there needs to be that nurturing relationship. We all assume that nurturing relationship is going to be mom. It may not be mom. It may be grandma. It may be grandpa. It may be Aunt Lucy. It may be a school teacher. It may be a nurse at the health department. But some nurturing relationship is what's going to help that baby have some resilience. So this just shows that skills build upon skills. And if you don't have that basis for those skills to grow, so they can grow resilience, recognition, routines, responsiveness, relationships. Think of your patients and how many of those things that you see on the outside of those red boxes that your patients don't have right now. This is really a kind of a scary PET scan, and this shows on your left side a normal, healthy brain. On the right side is a brain of a child who was put in a Romanian orphanage and not handled, not talked to, no interaction. And it just shows that the red is the more active parts of the brain, and the blue is the less active part. So there's no question, those brains are different. So when we say, well, what's wrong with that person? Is something wrong with their brain? There may very well be, because of those first hardwiring of the brain times. You've seen this before. I bring this up. This was my biggest aha public health moment when I realized my entire life work had been spent on that 20% of clinical care in that box in the middle column, and that 30% of what happened to my patients was what happened outside the office. 40% was environmental. 10% was physical. There is so much more that we do other than doing a pap smear, other than taking a blood pressure. This is just, and like I said, you're going to see this a lot through the day, but this is going back to the life course perspective. And this shows that some of those down arrows, poor nutrition, stress, abuse. If y'all would put your phones on mute, I'm sorry, we're getting a feedback from somebody talking. I apologize. So poor nutrition, stress, violence, you can read through these, and it makes sense to you. These are your down arrows, and that's where you get those poor pregnancy outcomes. When those pregnant moms are starting at a different spot than somebody who's been better advantaged. We're finding that those arrows now way back early, those adverse childhood experience, those dysfunctional families, that child abuse, and we'll go into a little bit more in a minute what an adverse childhood experience is. So the question was asked to a bunch of middle-class people that had Kaiser Permanente insurance, so they were insured, they were working, and in their 50s they said, hey, back when you were 18 years old, did you ever have any physical abuse? People will respond to that if you ask about their past, not what's happened to them right now. Did you ever have any physical abuse, emotional abuse, sexual abuse? Did you ever see your mother or your stepmother treated violently? And they go into detail, like was she ever hit, slapped, kicked, threatened with a gun, threatened with a knife, things that just blew my mind when I read the questions. Was there substance abuse in the home? Was there a mental illness in a parent? Did you lose a parent to separation and divorce? I think it's interesting it doesn't say death. It says separation and divorce. And was anybody in your household in jail? And you got a point if you got any of those answered yes. And what they found that those adverse childhood events on the bottom affected the baby's emotional and social ability and their cognitive impairment. Then they adopted abnormal or poor life health risk skills. They got into disability. They got into disease. And these people with higher scores die 20 years earlier than the rest of us do. So I'm going to zip through these. You're going to get these in hard copy. This shows I wish all the colors were the same, but I didn't have time to change the colors. But on the left is always either 0 or 1 of the adverse childhood events, and the further over to the right you get, the higher that number. This shows you this shows impaired development in the first 3 years of life. This shows you 3 groups. This is intercourse by age 15, teen pregnancy, or teen paternity. The higher your ACEs score, the more likely these things are to happen to you. This is initiation of smoking at an early age. This is either you became an alcoholic or you married an alcoholic. I mean, newsflash, the more adverse childhood experiences, you gravitate to somebody to help. You're trying to be a helper, an enabler. This is initiation of illicit drugs. This is chronic depression as an adult. The lighter colors to the left side, the lighter bars are women, and the darker bars are men. So it's much more pronounced in women, but it also affects men as well. Here are the ACEs scores and obesity. So all of these things are coping factors, things that we think are bad health. My perfect example is I had a patient, she was a smoker. So those of you who know me know that I actually had a patient tell me she didn't want to come to me, but the health department made her. And I said, oh, really? Why did you not want to come see me? I thought that was pretty bold for her to say that. She said, well, you don't like smokers. And I said, no, I don't like cigarettes. I don't like what it does to people. I love smokers, or I wouldn't spend so much time trying to help in any way that I can. So this patient came in and she was a smoker, and I was giving my little song and dance, my little medical, almost paternalistic thing I was doing. And she said, well, it helped me when I was young. And I said, how did smoking cigarettes help you when you were young? And she said, my daddy hated cigarettes. I said, oh, you were rebelling against him. She said, well, no. When he came in my room at night, if he smelled cigarettes on me, he would leave me alone. I taught my little sister to smoke too. And I said, sister, you smoke all you want to, because that was the only way she had survived her childhood. I knew there was a time when she could stop smoking, but right then wasn't there, and I almost lit up with her because, I mean, it's been 15 years ago. It still breaks my heart to say that. So we need to look at the way we look at our patients and try to understand how and why are they doing what they're doing. Those are their coping skills. So what we see as a problem is actually their way to have a solution to a bad experience. So their bad habits and destructive behavior may be pretty smart. They may be doing something that we're not even smart enough to figure out how to do. So these are ACEs that really struck me looking at heart disease. What happens to you in your early experiences? If you start overeating to make yourself invisible, you start smoking cigarettes, you start using drugs, you have multiple sexual partners, you do all the things that are coping mechanisms to make the pain go away, you're going to have heart disease. You're also going to have, I worked really hard on this slide, y'all look at this because this just took forever. It's so simple. But if your ACEs score is greater than 4, these are the percentage increase in the 10 leading causes of death in the United States. And I would venture to say that the accidents probably are associated with ACEs, but there's just not a way to link that. 1,220%. I don't think I've ever seen that number written like that before, but you're more likely to commit suicide. Well, that's not a newsflash either. That makes perfectly good sense. This is another list, and it'll be in your PowerPoint when you get it, so you don't need to write all this down. But these are all the experiences that are attributed to your ACEs. So early death because you've had childhood trauma, they identified 1,500 in the study that they did, 1,500 deaths in their cohort in those 10-year period of time. And these people that with an ACE score of 6 or more died 20 years earlier. That doesn't sound like a lot when you're 25, but when you're 62 like I am, and there's a difference between dying when I'm 60 and dying when I'm 79. My mother's 86 and she still lives by herself and drives to the beauty parlor and to church on Sunday and lives alone. That's my longevity, and I'm planning on taking that. So we know that these experiences, these ACEs, health risk behaviors, mental illness, social malfunction, disease, disability, death, I think you've got kind of the picture. When we look at this by race, and this was a study that was done, a BRFA study that was done in Arkansas, Louisiana, Tennessee, New Mexico, and Washington, and I am happy to say that we did have ACEs questions last year in our BRFAS. Our BRFAS committee allowed us to add ACEs questions. We don't have those results. I'm hoping by May that we'll see what Kentucky looks like. But you can look at your slides when you get them, and it shows that in the white group, almost 42% of them had 0 ACEs. And then you see that that number was smaller because more people in the Hispanic and Black group had a higher number of ACEs. So science tells us that early life experiences, it affects our immune system when you're stressed, and there's a whole bunch of science that shows when you are stressed, your corticosteroid levels go up, so there's a chronic inflammation going on in your body, and your immune system just can't deal with that, and it's so effective on your cardiovascular system. I put that in for the people, the geeky science people. It just kind of talks about that circle that happens. You have rapid heartbeat, rapid breathing, increased blood flow. Now that's one thing if somebody pulls out in front of me in the parking lot when I'm getting out of the parking lot, and all those things happen to me, but then it goes back down. But for these kids and these dysfunctional families, they are always on alert. They are always ready. So when somebody taps them on the shoulder at school, they're going to swing. They're used to someone coming up behind them and hurting them. They're going to do things that make sense to them in their world. And this talks about the gas pedal, the amygdala, and the hippocampus, the brake. So there's 3 levels of stress. There's the positive stress. You get scared when somebody pulls out in front of you. I drive by a daycare center every day on my way to way to work. It's at a church. I just am in panic stricken because parents open the doors. I'm driving down the street. They're pulling kids out. Little kids are running around. I mean, I drive 5 miles an hour past the Episcopal Church because I never know who's going to dart out in front of me. That gets over by the time I get down to Broadway. So you've got positive stress. You've got tolerable stress, and we've all been in pieces of our lives when we were stressed, but we handled it. But then there's the toxic stress that these kids experience all the time. That's what toxic stress looks like. I can show you all the slides in the world. That's what toxic stress looks like. Yeah, there are people in the room that can't even look at that picture. So this talks about what toxic stress does to your self-esteem, to your level of trust. And this is an interesting study, Washington State. If you had 30 kids in a schoolroom, they found that 6 of those students would have no ACEs, and then the number goes up, and at least 3 kids in every 30 children classroom will have at least 6 or more ACEs. And if you're a teacher, and I think some of you have some experience teaching school, you could probably pick those kids out right now when you think back to some of your classrooms. There was a bus driver who all of a sudden this kid started bullying the little kids. He'd never done that before. So instead of kicking him off the bus, he went to the frisky, I believe. They had a conversation. They pulled people together, and they found out that this child was being sexually abused, and they took him out of the home. So this little kid this bigger kid didn't start beating up little kids just because it was fun. He was acting out because of what was happening to him. Resilience, I wanted to be sure we get to this. Does this mean these kids are like faded, by age 3 you're just done? Well, no. The brain does have some resilience. Now, that's a hard thing to bounce back from, but we all know people that had, when you hear their life story, you think, how are they even vertical? I mean, how have they survived? Well, you can always find that resilience. Derek Anderson, for you Big Blue fans who know who Derek Anderson is, but his father left him, I believe, when he was 6, and his mother at age 11 just disappeared one day and never came back. He lived in the apartment where he had lived with his mother for months before one of the school teachers figured out that he was wearing the same clothes and to school because he didn't really have the ability to. Yeah, he had a child when he was 15, but he had a basketball coach and this one teacher that figured him out. They got him into Ohio State University. He got a basketball scholarship. He then got recruited by UK. He got his daughter back, and he went on to pro basketball. He did not do that without huge amounts of resilience and relationships that help that grow. And that's where we are key. That's where public health is key. And I think HANDS is our perfect example of resilience. And y'all all know the numbers, and y'all know what you do in your communities. But that shows how you can take those down arrows, those risk factors, and we can be those protective factors to help build these children back up again. This was interesting, and I didn't know this. I stole, by the way, Dr. Ruth Ann Shepard gets credit for this presentation because I just scavenged 3 of her PowerPoints and pulled all these together. By 2030, 90% of the morbidity in the United States or high-income countries will be non-communicable diseases. And those are almost all from unhealthy behaviors, and many, if not most of that, comes from the unhealthy behaviors that they learn because of their ACEs scores. So, adverse childhood experience are not destiny. Early trauma doesn't have to dictate these kids' lives. But research shows that protective factors, a nurturing adult in their life, can make a difference for these children. So a take-home message, 3 things. I guess there's 4 things, 5 things. 3 are highlighted. So exposure to violence and trauma is the single most prevalent risk factor for children today. And it was for children yesterday, and it was for 20 years ago, and it was for a decade ago. Adversity is necessary for learning. If everything is easy, you don't learn. I saw an advertisement in a newspaper that said, is our money making it easy for our children, or is it too easy? And they don't learn. So that there needs to be some bumps in the road. Those are good for our kids. But relationships are critical for that resilience. We need to address the lifelong toll that the ACEs show, that the effect they have on our patients. And knowing what we know, we can do better. And I think that's the theme of my last 6 months. I'm learning and going, hey, we know that we can do better with this. And our children deserve that. So that is the end of this presentation, and I don't know if we want to do questions at the end or how you want to do that, Libby. Now, this is where it's time to go get coffee if you've heard this before, but I will go through this again rather quickly because this is some basic cervical cancer 101. Many of you know, but don't run away completely because I have added some things at the end that I think we need to talk about. Everybody knows this bad boy. This is HPV. Actually, it's not HPV. HPV's inside there. These are the proteins that surround HPV, and these are the proteins that the HPV vaccine is made to react to. Once those proteins are broken or they're not there, the virus cannot survive on the outside by its own. So that's what we're our enemy today. I like this picture just because I think it's kind of cool that they know the HPV rate of every county in the United States. I'm not sure how that is, but you can just see it going right down Appalachia. And that's no big surprise to us. I got this off of Kentucky Cancer Registry last night. This is the last 5 years of data. Those dotted counties mean that statistically the numbers are low and all that epidemiology voodoo that they do, but it still gives you a trend. It tells you where you would expect in the bigger counties to have more, but you've got more going on in Warren County. No, wrong. That's not Warren County. Warren County's yellow. Anyway, where you've got more people, you would expect that, but you're seeing it in a lot of our under socioeconomic counties. And then here is the very same time frame a year back, because we don't have all the mortality data yet, for counties for mortality. People die of cervical cancer. I never stop saying that when I do a presentation because people don't think about that. They think it's from the past. I updated this as well last night. These are the number of cases of cervical cancer and the number of deaths. When we look at that, to me, the take home of that is those numbers really haven't changed. with all the work that we're doing, with everything that we're doing, we have, except for 2004, we have had at least one woman a week in the state of Kentucky die of cervical cancer. And that should make us not be able to put our heads on our pillows at night and feel good about that. Now, we do feel good about all the other women that we've kept from dying of cervical cancer, but this is something that we cannot, it's only 67 women. Well, 67 families, 67 children without a mother. This is devastating, and we need to keep waving that flag. It's not the biggest cancer that women face, but it is a preventable cancer. What we know now, we should be able to break this. So this is just a little bit of history where we've come with cervical cancer. There are people out there that do not understand. We have not had pap smears forever. Dr. Peckin, I can say that word when I'm not on the screen. Nikolai developed the pap smear in 43, not for this reason, it just kind of happened, and that's another long story. But we're now getting much better at figuring out how to use that. For those of you who don't know much about the anatomy, this is, I think, a pretty decent picture that shows you what a normal cervix looks like, and as that cancer spreads into the cervix. So why do we have new guidelines anyway? What's wrong with what we were doing? Well, ACOG, American Congress of OBGYN, ASCCP, ASCP, American Cancer Society, that's the Association of the American Society of Cervical Pathologists. They all got together and said, you know what, let's look at the science, and let's look at risk versus benefits. And that's what makes it hard for us. Because prior to the 1980s, we screened everybody every year. We just did. That's what we did. Why did we do that? What was the science based on doing a pap smear every year? Well, sounded good. We didn't know. So if you do it every year, that way you don't forget. And if you miss 1 year, you know you need to do it the next year. What we have now is much more complicated. So the good old days was we just did it every year and we didn't have to think about it. Now we have to think about it. Now we have to do some introspection and really look at the patient and decide, does this person need this or not? So I know you guys know this. I'm going to go through these. Under 21, we don't recommend pap smears. It's extraordinarily rare. It does happen, but it is extraordinarily rare for people to have cervical cancer. But it's not abnormal to have dysplasia. I cannot tell you how in the 90s I chased dysplasia, mild dysplasia in 15-year-olds. Well, I'm freezing their cervixes, burning their cervixes, cutting parts of their cervix off at 15. If I had left those people alone, they would have been fine. I didn't know that at the time. That was not the science. That was not the recommendation. Certainly, if you see something, if you're down there for some reason, which is unusual anymore, but if you see something, biopsy it or refer it or pap smear it if you want to. So don't ignore it because of these guidelines. That's where that risk-benefit thing has to come in. But it's not a routine, absolute thing. And what that's done is it has allowed younger women to come and see us and not see us as the enemy. They see us as someone who can help them, who can give them birth control pills, who can check for STDs. 21 to 29, you do a pap smear every 3 years, and there's exceptions. We won't go through that. There are perinatal risks associated with LEAP, so cutting off parts, even small parts of people's cervixes, can cause problems. And then these are the things that it doesn't cause. Then 30 to 64, that's when you do the pap smear every 3 years, except in those situations, or every 5 years if you co-test with HPV. And I think we've gone over that before, but I'm happy to answer questions if anyone has it. And then the recommendations right now is nobody over 64 gets a pap smear unless they've had an exception, and those exceptions are listed here. So why did we add the HPV to the pap smear? What's the reason for that? Well, it makes it more specific. It makes us, more sensitive. HPV is less specific and has a higher, adding the HPV is a higher predictive value. So what that means, because I always have to go look that up. I took 2 semesters of statistics, one in grad school, one in medical school. So it makes it more likely that if it's positive, the person really has the problem. It's less specific because that means that if the test is negative, the person's probably okay, like a belt buckle in the airport screener. You know, you'd rather catch a few belt buckles and not miss the bombs All right, so that's what the specificity is. And then the higher predictive value says that the number of negative tests are more likely. This is what we want our pap smears to do for us, and the HPV helps us with that. So this is a big study that I won't go into, but the bottom line, after 6 years, they did a pap smear on these women, and the risk of SIN3 or cancer was 0.28% if the person had a negative pap smear and a negative HPV and had nothing done to them for 6 years. So that's 0.28%, which is a very small number. The risk of SIN3 was 0.28% if they had a negative HPV. We're not going to get in today whether we just should do HPV alone and not pap testing, because that's not the recommendation yet. Will that come in the future? Maybe, maybe not. I'm not sure that. I know that the jury's still out on that. And if the person had a pap smear and nothing in 6 years, she had almost a 1% chance that she might have a SIN3. We'll go through that. I like this slide. Again, it's a picture. I can follow that. So these are months of time in a patient, and up the side is the risk of SIN3. And the brown line at the bottom is the patients that had a negative pap and a negative HPV. The green dotted line is if you had a positive pap but a negative HPV. And then as you go up, the blue line is someone that had a positive pap, had a positive HPV. Their risk of having SIN3 was much, much higher. Screening after hysterectomy, real important now that we're doing supracervical hysterectomies again. Do they have a cervix? They don't have a cervix, makes a difference. And these are all listed. I think the thing that I used to say, well, I didn't want to miss vaginal cancer. And some of the reading I've done says, well, the risk of a woman having vaginal cancer is the same risk of a man having breast cancer, but we don't mammogram men. So that kind of put that in perspective. Yes, I might catch a vaginal cancer, but how many pap smears do I have to do to find that person? I think what we need to in public health to remember is we, no matter what we do, will miss some things. If we pap smear people every year, I had patients that I did a pap every year on, and they came in 1 year and they had carcinoma in situ of the cervix. And I had the pathologist go back and pull the slides, and it just wasn't there. Now, probably because in the pap smear, the cells didn't come off, or I didn't wipe them, or they didn't show up on the slide. Whatever the reason, we cannot do perfect screening. It is not possible. For us to do that, we would spend enormous amounts of money, and I know people don't like to talk about money when you're talking about patients' lives, but we are trying to get our spread. That's what we try to do in public health, and screen those people that are high risk. So, yeah, you know, people come in the health department, and until we get our universal medical record for everybody, well, who remembers when their last pap smear was? Shoot, I don't remember when my last pap smear was. I remember people coming in. I don't remember my last
participant to join the conference.
Oh, good. I don't remember when my last pap smear was. I don't remember when my last period was. I'm like, didn't you know you were coming to the gynecologist? Didn't you look this up? And then I do the same thing. Plus, I wear a shirt that you can't roll up your sleeve to get your blood pressure made. So I'm the world's worst. But if you don't know if they had a pap smear, you do one. You just do one. And then you educate them that even though they have already had a pap, they still need that annual exam, because a pap smear is not, a pelvic exam is not a pap smear. I went to the ER last week and they did a pap smear. No, they didn't. But that takes some education. So what are you going to do with all this extra time if you're not doing a pap smear, right? You know, you're not doing that. Well, there's lots of things you could do, and you know what those are. STI screening, talking to them about that, talking to them about family planning. I mean, this will really free us up to do some talking about things that are very specific, getting that risk-benefit ratio. Having said all that, this is the recent copy. This is March 2016 of the Green Journal. For the you that don't know, this is the journal that we use in ACOG. And there's a whole article on cervical cancer screening, and it's some big names, and they review everything. I didn't get into treatment today at all, because I know that's not what y'all do directly, but I know you need to be aware of it for your patients. So this is a big article where they've taken everything that everybody's recommended and just did a nice review of it. This article I have, however, I printed out of the February Green Journal, which is up there, and this is increased cervical cancer risk associated with screening at longer intervals, which is what this article's talking about. And their summary or their bottom line is, the authors believe that a significant number of patients and providers would not choose to accept these additional risks if they understood them, despite the recognition of potential harms associated with more intensive screening. One of the authors is currently the president of ACOG, Mark DeFrancesco. So people are still disagreeing. I know we're using, in our program, we're using the most current recommended guidelines. There are still people that disagree with this. Now that we have, before, we didn't have any science, so we just did it every year. Now that we've got science, you show two people the same study, if you show two physicians the same study, you may get three opinions. So this one is still in, some people are still disagreeing that this is the right way for us to do things. But right now, we're following the recommendations of the larger organizations. But yes, this is still something that people are grappling with. So the summary of the article in the Green Journal is, remember, most people with cervical cancer have never had a pap smear or haven't had one in the last 10 years, which is why CDC is so big on those rarely or never screened. Two patients I've told y'all about when I first moved to Frankfurt. I thought I was coming to Mayberry, Kentucky. There would be no illness here. Everything would be sunshine and rainbows. And it's Friday afternoon, and I've just taken my heels off, got my feet on the desk. I get a call from the ER. Dr. So-and-so is seeing this patient. She's bleeding heavy, and he can't find her cervix. And I'm thinking, I'm an OB doctor. ER doctors, what do they know? So I sashay myself over there. I put the speculum in. I get the blood clots out of the way. I can't find her cervix either. She didn't have one. She had a cervical cancer that had completely eroded her cervix, and she was just gushing blood because, for those of you who've done OB, you know that the uterus has some pretty impressive blood vessels, even when you're not pregnant. A month later, the same thing happened. Both of these women had had their tubes tied in their early 40s, late 30s. They didn't like doctors anyway. They weren't going back for anything. And they both presented, and we hung blood, and we shipped them to UK so they could radiate them immediately just to stop the bleeding. I failed to follow up with those women. I don't know what happened to them. But I was so emotionally traumatized by that. And for it to happen 2 times in 2 months, I thought, man, I need to move out of this town because this is scary. That never happened again. But those are the kinds of things that you have seen. I had a patient that came in. She came in because it hurt when she had sex. She was in her early 50s. I examined her. I did a pap smear. She had cervical cancer. We did her surgery. We got her all taken care of. She did great with her surgery, despite the 2 packs of cigarettes a day and the fact that she weighed 105 pounds. I just figured she would just crump through the surgery. She did great. She came in for a postpartum visit. I was so proud of myself because I had saved this woman's life. And she looked at me and said, it still hurts when I have sex. So I had done nothing for her. She had come for having painful intercourse, and she still had it despite everything I'd done, and did not get the fact that the surgery was not supposed. She thought the surgery was going to make her be able to have less painful sex. And I was just aghast that she had already had surgery and found that, or had sex and had found that out. But I hadn't done anything for her. So what we need to do is focus our outreach to the critical groups. Yes, we need to do everybody that we do, but that's why our outreach is so important. And that's why the program here is so into getting us outreaching, the navigators, all of those kind of things, the mobile units, and the work that y'all do. Blacks and Hispanics have higher rates than whites. Rural women have higher rates than urban women. Those are the things that the Green Journal was telling us we need to focus on as we're working with all this science of HPV. So obviously that didn't work out. So the steps there, I call them action steps. The things that they said in this article to maximize your efforts, be attentive to the guidelines, and we beat y'all up with the guidelines. I think y'all got the guidelines down. Assure that women, and they didn't, I'm going to write a letter. I've never written a letter to the Green Journal. They said assure that women have access to appropriate HPV vaccination. I'm going to write them and say they need to make sure that men have appropriate access to HPV vaccination, and provide low-risk, high-quality screening and treatment. And this is something that you all do every day. Don't forget, there are people out there that are scared of HPV. This cartoon says, this new mandatory STD vaccine won't hurt a bit. And on the syringe it says, uncertain safety, corruption, erosion of patients' rights. There are people that feel that way. We have to respect that. They have those opinions for some reason. But we have to figure out a way that we can work with them and compromise for the good of their children. I am showing you, and I know I did a whole presentation a few years ago on your smartphone and how it can help you in your women's health work. This is the ACOG app that anybody can get, and you can click on that. It's free. And it has different places that you can click to, and the immunizations one is the one that's important. And so you can tap that and you can put the person's age in, and it will tell you all the immunizations that she will need, including your HPV vaccine. If you don't have this one, at one point this thing cost $10, and I was ready to pay out of pocket so that every one of you out there working can have this. It is now free, thank you. But this is the ASCCP, and this is there where you put in the age, you put in the HPV status, you put in if they're pregnant or not. You click on their cytology results, and it will then tell you what you need to do on how to treat this person. I mean, it is awesome, and I know a lot of you are using it. I would never be able to keep all this in my head. Back in the olden days when we had hammers and chisels and we just, we stone tablets that we wrote on, this was easy. But now there are so many complexities, and it helps us to not overtreat our patients, but it keeps us from not doing the wrong thing. This, I don't think, if I was still seeing patients clinically, I would let this out of my sight. And so this is what you click on as to what their Pap smear results are. So I got 2 minutes over my time, so I apologize for rapid fire. Most of you know all of these things. You will have the hard copies. Let's take a couple of questions if there are any in the field. Thank you so much for letting me come. One year they didn't ask me, and it really hurt my feelings because I thought I'd done something wrong. They were trying to alleviate my schedule, but as I've said before, women's health is my heart, and I love to be a part of this division. I love to be a part of what you do out there. Every morning when you wake up and say, why am I doing this? You're doing this because you're that protective factor, you're that up arrow for all of those patients out there that have got somebody with a hammer doing risk factors, beating their overall life outcomes down, beating them up with their before age 3 and continuing to do that. So anything we can do here at Frankfurt to help, I know we're from the government, we're here to help you, doesn't sound right, but I think you have had enough experience with the programs here in the Women's Health Division to know that we really do mean that. So, anybody have a question out there that I can answer? Okay, hearing none. If you have one, and I should have put this on my PowerPoint, connie.white@ky.gov. That's my address, and I'm sure you probably have Melody's address and all the people in the cancer program. Obviously, the family planning and adolescent work that we're doing is another resource. And we also have here with us in the room today Vivian Lasley Bibbs from our Office of Health Equity, and she's got a great wealth of experience to help us with this. So please let me know if you have any questions. If I can't answer them, I'll find the right person that can do that. And thank you for having me very much today.
Good job. Thank you, Dr. White. We always appreciate your willingness to share your expertise with us. Our next presenter today is Ms. Vanita Decker. She's our Family Planning Program Director. She's been in that role since September. Prior to that, she served as the Adolescent Health Initiatives Coordinator at the Department for Public Health for the last 7 years. Her background is in women's health in the hospital setting. She has a lot of great information to share with us today. Thanks for being here. Thank you.
There. Good morning, and thank you for letting me come. I'm also going to kind of do a whirlwind presentation just because I have a lot of stuff to share with you today, and so we'll just get started with that. These are our objectives. We're going to talk about the importance of family planning. We're going to talk about adolescent health because it's my passion too, and then we're going to talk about some family planning updates, especially around reimbursement and some things that are coming down the pipe. Okay, I know you all know the benefits of family planning, but over the last, especially the last 3 years or so, our family planning numbers, our FPAR numbers, the people we're serving in our local health departments through our Title X grant have halved. We served about 47,000 women last year. In 2014, we served 69,000 women, and in 2013, we served almost 90,000 women. So we've almost halved our numbers. And so I just want to remind us in the trenches, to maybe advocate to your directors of why it's so important for us to provide family planning services. It affects literally everything, everybody. Also, to let you know that, the number of women in need haven't, disappeared. In 2013, according to Guttmacher studies, 281,940 women in Kentucky are in need of publicly funded contraceptive services across our state. And 131,550 of those women are 137% or more below the federal poverty level. So we're not meeting the needs of our women in Kentucky. And I realize with ACA and Connect that some of those numbers may be better, but we really need to beef up our work. Why do we need to beef up our work? First of all, family planning is more than contraception. I think listening to Dr. White, that's more than evident. It ensures access to preferred contraceptive methods. It's essential for securing the well-being and autonomy of women. And it honestly supports the health and development of communities, because if we have women who are having pregnancies that were unplanned, it kind of puts a whole cramp in what their life goals were, and it increases poverty and so forth. It also provides us better health. It prevents health risks. So allows spacing of our pregnancies, can delay pregnancy in adolescent women. We're going to talk more about that in a minute. It prevents unintended pregnancies, like I said. And it also, so those women who keep having baby after baby, it increases their risk for a high-risk pregnancy. And so it causes more financial burden on our healthcare system. It also it contributes to all those ACEs that we've talked about. I've got 6 kids in my house instead of 2 or 3. I cannot divide my time between them. I live in crisis of the moment every day of my life because I live in poverty. It leads to more, sometimes more abuse and neglect, and it really increases those ACEs in our children. It enables, but also family planning enables our women to limit their family size if they wish to do so. I know families. I have several friends who have 6, 8 children right now and do that well. They were planned pregnancies or planned adoptions, some of them. They planned that, but when it's unplanned, it becomes a whole new ballgame. Okay? It does reduce infant mortality and maternal mortality. Family planning can prevent closely spaced and ill-timed pregnancies and births, which contribute to some of the highest infant mortalities across the world and even still in America. Infants and mothers who die as a result of giving birth also have a greater risk of death and poor health. When you lose your mother at birth and life gets crazy, then those ACEs really come on board. But providing family planning also contributes to a better opportunities of economic stability, not only for the patient, because it increases their opportunity to pursue their education, their career, to have a more financially stable life. Smaller families allow parents to invest more time in their children, which leads to less ACEs and more opportunities for them. Children with fewer siblings tend to stay in school longer just because of that whole dynamic, especially with people in poverty. And it also increases the opportunity for community involvement. It honestly makes your community healthier when you have healthier families, and that just makes perfect sense, okay? And it contributes to a decrease in teen birth rates, dramatically so. And so while we're on the subject, let's talk about adolescent health, my passion, okay? We do continue to we are falling in our teen birth rate. Some of you have heard this speech over and over again, and I will preach it to the end of time. We're working hard on that, and it's working. In 2005, well, actually, if you look at 2008, our teen birth rate, which is one I like, it got the highest it was in the last two decades. It was 55.8 per 1,000 girls 15 to 19. It's now down to 34.5. Here's the 2014 teen birth map. I know you all probably are saying, where's my county, where's my county? But the significance is, here's the 2018 birth map. All the pinks and reds and maroons and stuff show those, oh my gosh, high teen birth rates. And we strive for white. Blues are pretty well around the national rate. But then look how much better we are. Look at all our blues and grays and whites now compared to 2008. Still have some issues in eastern Kentucky. In fact, in Appalachian counties, while Kentucky has decreased their birth rates by 37.5% since 2008, Appalachian counties, the 54 Appalachian counties, have decreased theirs 26.3%. This past year that we haven't gotten 2015. 2014, your birth rates, you were at 46 per 1,000 females ages 15 to 19 compared to 62.4 in 2008. But you've slowly trickled down, but that's the best you've ever been ever. And so that's great. It's because of all the work that's being done in the health departments and not only through the family planning services, but also through your community action, through education and that kind of thing. But look, it's the Appalachian counties have done a little bit better. And poverty plays a huge role, an absolutely huge role. And so we are working very hard with a multi-pronged approach to address teen pregnancy. We're still 10 to 12 points higher. Right now we're 10 points essentially higher than the nation, but we run between 10 and 12 points higher than the nation, even with all our successes. And boy, I would love to close that gap. Some other statistics. On birth certificates, there were 1,202 teen fathers reported on birth certificates. They were between the ages of 15 and 19 in 2014. There were more than that. As many of you may know, that teen fathers have to, if you're under 18, if you're over 18, we'll go backwards. If you're over 18 and you are the father of a baby, because most girls under the age of 22 are unmarried, about 85% of our girls under the age, women under the age of 21 are unmarried when they have their babies. And so if you're under 18 as a father, you cannot sign your paternity paper. If you're over 18, then the hospital has incentives to make sure that all paternity papers are signed for our unmarried mothers. Okay, but if you're under 18 because you're a minor and you're not emancipated, you have to go to a health department and sign that, or here to Vital Statistics to sign your paternity papers. Okay, well, you can imagine they get out of the hospital and that just doesn't happen. And so only 1,202 teen fathers, and most of those were probably 18 and 19 years old, signed their paternity papers. So that's probably not an accurate number. Teen births to girls 18 and 19, which traditionally, that was when we've always started having babies. It's not as much as was society even 50 years ago, but there's still 75% of the teen births are to our 18 and 19-year-olds who are either just out of high school or seniors out of high school. But still 25% are to high school teens, 15 to 17. And that hasn't changed. So all of our work, we are lowering our numbers overall, but we're not closing that gap on our high school teens. And so it's been about 25 to 26% for as long as I've looked back at data. The number of repeating births, meaning it's their second, third, fourth, fifth child by the time they're 19, is down to 18%, which was 26% in 2008. So that's getting a lot better, encouraging our girls, even once they are a parenting teen, not to do that again, is working, and providing birth control is really the key for that. The number of births to girls under age 14 and under, 14, 13, 12, there were 44 of those in 2014 compared to 86 in 2008. There were 45 in 2013, 64. We're really dropping those numbers. And I think anybody out there would say that anyone 14 and under does not need to be having a baby. And so we are working through education and stuff, and it is helping to not have those really young mothers. Just looking at the Youth Risk Behavior Survey, I'm going to go over some of this data. It may be aha, it may not for you, but it's just kind of good information to know as you take care of your adolescent patients, what they're going through. 41%, almost 42% of our high school teens report that they have been sexually active. If you look on the scale, it gets higher and higher. Like our 12th graders, almost 60% have been. But it's going down. Like In 2011, just 4 years ago, it was almost 52% said that they were sexually active. So there is a decrease in what the experts call sexual intendedness, where kids just are waiting and delaying to have sex. It's still 42%, but it beats 52. Okay, and 10%, 9.7% of our middle school students report that they have had sex, which it was 17.2% of our middle schoolers said they'd had sex in 2009, 10% in 2013. The YRBS, the Youth Risk Behavior Survey, is done every other year on the odd years. It's pretty evident. 54% of the sexually active high school students report they used a condom with their last intercourse overall. And 53% of our middle schoolers who have had sex said they use a condom. But sadly, that's down from the 2013, that 69% of our middle schoolers said that they had used a condom when they had sex. 10.4% of sexually active high school students report they've had sex with 4 or more partners. And look, by the time they're in 12th grade, 17.6% say that they've had sex with 4 or more partners. It is going down, though. Overall, that 10.4%, it's steadily decreased due to education, teen pregnancy prevention activities. 3.1% of our sexually active middle schoolers say they've had sex with 3 or more partners. And so it's not a high percentage. It should be 0. And that's just some information. Other information about sexually active students, said 17.1% say they drank alcohol or used drugs before their last sexual intercourse. And then just here's your some of the birth control statistics, and this is students self-reporting. 5.2 females said they used an IUD or an implant, like Implanon. 22.4% said they used birth control pills. 6.1% said they used like a depot shot, patch, or ring. And then 11.6% said, excuse me, that they'd used a condom along with another form of birth control to try and prevent STDs, which still isn't a very good number, but it's up from 6.6% 2 years before. So again, education is key. Just some other youth risk behavior survey, just stuff so you know as your teens come into your clinics what they're facing. It's down significantly, but 5.7% said that they had smoked cigarettes on 20 or more days in the past 30 days, which is down from 12% in 2009. 12.65%, actually 6%, my 5 should be a percent, said they were using dip or chew of some sort. And then 23.4% said they use an electronic vapor product. So the concern is not that they're decreasing their cigarette use, but they're just going to an electronic product. In fact, more kids are using electronic devices than used to smoke using normal cigarettes. So there is a concern. As far as drinking goes, 28.5% of high schoolers say that they have had at least 1 drink of alcohol in the last 30 days. That's 1 in almost 3, okay? And then the percentage of high schools who have had 5 or more drinks, in other words, they got drunk within the last 30 days was 17.7%, which is it's about what, 1 in 6 are doing that. So it's a concern. Make sure you're talking to your adolescents about that. Drug use, 33.1% have used marijuana more than 1 time, 1 or more times in their life, and 17.2% have used in the last 30 days. It's a big drug, and they don't think of it as a drug, okay? They think that it's just the norm. I mean, they're legalizing it in other states, and so high schoolers do not look at that as a risky drug. 4.6% have used coke. Only 3.7%, which it should be 0, have used heroin. We always think that the heroin problem is more in high schoolers, but really they usually in high school tend to use some gateway drugs, and heroin usually is more of a drug used in your 20s to 30s. No one usually I'm not saying it doesn't happen, but most of the time heroin does not start out being the drug of choice. It usually is something that's built up to heroin, except it's so cheap now that we're seeing a little more of that. Okay, and then also 12.7% overall said they have used prescription drugs without a prescription. Those of you in Appalachian know that those numbers are probably a lot higher. That in the Appalachian area, that does tend to be a little bit more of the drug of choice, although I think that that's changing also into that as heroin trickles down into our state more strongly. Heroin is, as you all know, an epidemic. So don't shy away from those questions when you're talking to your teenagers. Violence, 23.1% of high schoolers carried a gun, knife, or club on one or more days in the last 30 days to school. 8.9%, 9% say that they've been abused by their partner through dating violence one or more times in the last year. I mean, that's 1 out of 10 of our kids, okay? And then, of course, it's a lot higher in girls. I think if I'm trying to remember the statistic, it's probably like around 20% of our girls, but it's boys and girls together, and so that brings it down to about 1 out of 10, 1 out of 9. As far as being bullied, 47% of our middle schoolers say they've been bullied on school property, 22% of our high schoolers. Middle schools, there's tremendous more bullying going on. And then as far as bullying electronically, 24.3% of our middle schoolers, 17% of our high schoolers say they've been cyberbullied. And just some other highlights, just to finish this whole section up, is that the students who felt sad or hopeless almost every day for 2 or more weeks in a row during the past 12 months, 1 in 3 of our high schoolers, we don't ask our middle schoolers, 1 in 3 of our high schoolers have felt depressed, sad, or hopeless. And they're coming into your clinic, okay? Percentage of students who have seriously thought about killing themselves, 18.4% of our middle schoolers, 15.7% of our high schools. Suicide is still the number 2 cause of death in Kentucky for ages 12 to 20. And so it's a problem, and one that we tend to bury our head in the sand about. And I think all of us maybe out there can think of a student that we've either read on the news or been in our community who has committed suicide. It's a huge problem. And percentage of high school students, I just threw this in, who have texted or emailed while driving is 36.5%. I wonder if it's either they don't have their license or they just didn't want to admit it. I wonder, because that it's still 1 in 3, but I wonder if it's a little higher than that. Then this last one I put in red because this is where you come in especially. We started asking in 2013, we asked students if they had an adult in their life that they can trust and talk to about serious problems. That's become a problem across, as we talk about ACEs, as Dr. White talked about. So in middle school, 12.5% of our kids overall say, I don't have an adult in my life to talk to about serious problems. 13.9% of our high school students. In 2013, 16% of our high school students reported that they don't have an adult to talk to in their life, a trusted adult about serious problems. When you put in factors such as poor grades, or even our students who identify themselves as homosexual, having sex with the same sex partner, those numbers go up exponentially to 30 and 40% say they don't have a trusted adult in their life to talk to. You may be that only trusted adult in their life that they can talk to and can trust and talk to about their serious problems, and not just their sexual health problems, but all their problems. Local health departments have the credibility and the influence in their communities to help guide community members to take adolescent health seriously. So not only do you impact your adolescents, you can impact your community to take more investment into your teenagers. What teens want when they visit your clinic are 2 things. They want respect, and they want confidentiality. They want you to keep your mouth shut. And we say, well, of course we're going to keep our mouth shut. And I think some of you have heard me say this before. But the teens' #1 reason why they don't want to go to the doctor is because they don't feel like they'll be treated confidentially, that somebody's going to call their parents, that when they, or they bring their parents into the room, even if your parents come with you to the clinic, keep mom and dad out of the room, and say, this is my conversation with them, we'll bring you in later. They want that confidentiality. Ensure them that they can trust you, that you are going to take care of them and keep their conversation confidential. Another thing you need to do is you need to help teens take responsibility for their own health by helping them learn how to think and not just saying what to think. Just say no, don't do it, just do this. You shouldn't be doing that. That's not going to be helpful because, like Dr. White said, you don't know exactly where they're coming from and why they do what they do. So use open-ended questions like, you know, a kid says, I want to have, you know, pardon my language, I'm giving my boyfriend blowjobs, okay? Or I'm smoking marijuana with my friends on the weekend. Instead of saying, well, you shouldn't be doing that, instead say things like, well, why are you, I mean, what's the good and bad of doing that? Why do you do that? So how is that good for you? But how is that bad for you? What are the bad things? What are the good things? Help them think through their situation. You learn a whole lot more from them, and they own their choices by you responding back to them respectfully and just saying, hey, let's talk more about this, and let's figure out why you're doing what you're doing, and let's figure out some alternatives, and let them own those decisions. So here's some actions real quick that can make your clinics more teen-friendly. Some of them you're going to say, we can't do that, but just strive for these because it makes it better. First of all, I took out the extend long hours. So, you know, if you're having your clinic hours while they're in school, that's not productive. They can't get out of school to sneak over to the health department. If they do, they're probably like skipping class or whatever. Or even when their parents bring them, you want to extend the hours maybe one day a week or month. This is so that they will have the access to your clinic, okay? Also, use electronic media. They live on their cell phone. It is their right arm. They cannot survive without it. They can, but in their brain, they don't think they can. So use Facebook and Twitter. If you have Facebook accounts on your health department, let your kids know about those Facebook accounts. But then every week, put something up, tweet something about adolescent health, tweet something about or put something on your Facebook about, you know, something that's going to entice adolescents to be more responsible about their health. Use YouTube, a national campaign. There's lots of great videos that you could set up a laptop in your waiting room or while they're waiting in the exam room. Or they can get on. There's bedsider.com. There's stayteen.org on a national campaign. These are free websites that you could set up in your clinic rooms on a laptop, or on an iPad, and let them be looking at those while they're waiting to see you. There are other YouTube videos that are really informative. There's a lot of different websites. You just have to Google, you know, healthy teens. There's just tons of stuff out there that you could, you know, and you say, well, they'll just steal my iPad. No, they won't, because you're going to watch them while you're in the room. Utilize that, and they'll think you're totally cool for having an iPad or something that they can watch stuff while they're waiting to be seen. Provide, I did put this in, I thought I took it out. Provide some same-day scheduling and walk-in abilities for teenagers. Have some adolescent health friendly messages in your waiting room or your lobby. If you find a poster or something like that that you think would be really good to hang in your lobby, or you don't even know, call me. I have tons of resources where we can give you some posters or something to hang in your waiting rooms that would catch the eye of teenagers. Advertise your services at the local middle and high schools and college and career sites. Let your adolescents know you're out there. Another population is our emerging adults, our 19 to 22-year-olds. Let them know you're out there and that you are there to serve them. And ensure confidentiality through policies and corrective actions. When you find out that confidentiality has been broken, make sure that you fix that and don't let that happen again. And reassure your clients. We did focus groups about 5 years ago with teenagers across the state, and almost every single focus group said, I don't go to local health department because my friend's mom works there, and let me tell you, she's just going to call my mom when I come in. I can't go to my doctor's office because the same thing happens. So teens are out there feeling pretty vulnerable and just, you know, so they just don't do anything, okay? So, and of course, we're always going to engage parents whenever possible. That is a primary goal of Title X funding and family planning. You know, you got a teenager comes in and she or he wants some kind of family planning services. While you're taking care of them and while they deserve that treatment, always say, how are we involving your parents? When they say, I don't have a parent I can talk to, say, well, is there another trusted adult in your life that we can talk to, because you need someone to support you through these decisions. And so make sure you're open to that conversation and involve them. And another thing that is, everybody's like, oh my gosh, this is kind of crazy, but it's been proven in many places, engage teens in your works. Consider teens working in your local health department. They'll work fairly cheap, minimum wage. Can they come in after school and do some filing for you, or do something else? I don't know. And so you have them a couple days a week, and believe me, they will influence your decisions and bring a lot of information to you to help guide your work. Have them on your to volunteer maybe they're allied health students and they need to have some experience in public health, or have them on your committees or action groups. Teens are smart, and they will provide a lot. In fact, the adolescent health specialist in adolescent health is Tiffany Logan, and her sister is 17. And in the last year, as she's been on board, whenever we make a decision, we send everything to Tiffany's sister and her friends, and they let us know if we're right on cue or not. So, if you've got teens out, you got parents of teens in your health department, and you're thinking we're going to do this for teenagers, then say, well, let's run it by the teenagers to see if this is effective or not. I thought it'd be really cool to give out. Don't laugh at me, I'm so old. These really cool rulers at the state fair, and so we ran it by the teenagers, and they said, "Oh, you've got to be kidding! No, that is so lame." And so, of course, we didn't do that. They wanted bracelets, and we've been doing bracelets over and over again, but they wanted more bracelets, so that's what we did. So it's really important to engage your teens. They're smart, and you will learn, and because they have a culture all of their own. And if you try and come at them, well, I'm a grown-up, they're just going to shut you down. They want relationship. Especially our teens in poverty, our teens in disadvantaged and disengaged families and dysfunctional families. You may be the only person they are going to be able to feel connected to and talk to about things. The other thing I always say is, if you're at McDonald's or one of the restaurants and you've got a teenager serving you, compliment them. Don't be condescending, but tell them they have nice hair, or you've got beautiful eyes, or it's great. How's your day going? Because you may be the only person that day who pays attention to them as a person. And it makes a difference for them. It increases their self-esteem. It makes them, I think, as a community, we've got to start engaging in our teenagers. You do make a difference. So enough about that. Let's talk about family planning updates. I'm doing pretty good. Okay. First of all, let's talk about reimbursement. As most of you know, on July 1st of this fiscal year, we changed. It used to be that we reimbursed local health departments, whatever their allocation was, 1/12 each month to cover family planning services. That was not effective. Maybe was effective in its day, but it became ineffective. So we've developed a fee-for-service reimbursement policy, and it was implemented July 1st of the fiscal year, with the fiscal year. We did that, and we didn't know exactly how health departments would spend. We didn't know how that would work. So when we sent out our CPT code list that we were going to cover through the 802 cost center, or with the Women's Cancer Screening Program, we're covering our pap smears and our clinical breast exams. We made that list and said in 6 months we would evaluate it. We did not include STD testing. And so what we did was last month, actually in January, we evaluated that process and realized we could pay for STDs, retroactive to July 1st. We also had decided, because there's a 10% match with family planning and because of this new reimbursement policy, wasn't sure, even though you historically put in a lot of local dollars, wasn't sure that was still going to happen. So what we realized, so we reimbursed you at 90% of the Medicaid preventive rate, which would that would take care of your 10%. In evaluation in 6 months, we found out that you were still putting in a lot of local dollars. So here's the changes that are retroactive to July 1st. First of all, we're going to reimburse at 100% instead of 90%, and that'll be retroactive. We also are including these CPT codes: chlamydia, GC, syphilis, VDRL, hepatitis C antibody screening. That's not the rapid screen, the hepatitis rapid screen, because you get kits to do that. So we're doing the antibody testing, which is the confirmatory test for Hep C, and then the HIV confirmatory test. Same reason we went to these programs through the lab and stuff. You all get the money to you get the kits, and so it would be double payment for the rapid screens. But the HIV confirmatory test for those positives, we're also paying for. We also added the Loletta. It was not before, there wasn't. It's new, and so we added that as one of the methods. We also, just really quick, the preventive fee schedule for Medicaid. Currently, first of all, on January 1st, they changed their code for Mirena. It was J7302. It's now J7298. That won't matter so much on your PEP. We're working on setting that up. It will matter if you're billing from your Medicaid patients. So make sure that you have that new code, J7298, as you bill for your Medicaid clients for their so you can get reimbursed for that from Medicaid. We're working on updating the PEP. Also, Skyline and Loletta are not currently on the Medicaid preventive fee schedule, and Women's Health and Local Health Operations is working with Medicaid to get this taken care of and getting it retroactive. We've not heard recently. We've been working on that about 3 or 4 weeks. I've not heard an update on where we're at on that. You know, that's a process, and so as soon as that's done, we'll let you know. But again, you can bill for it for your. You can bill for Skyla, Loletta, and Mirena with the old code even on the PEF. Okay, we're working on updating the PEFs to make sure Skyla and Loletta are put on this PEF. You can write them in though, and if it's not there, you can write them in until that PEF gets updated. It will not pay for your Medicaid patients, Skyla and Loletta, but you can pay for your Title X patients that are uninsured or underinsured with that sliding scale fee with Title X dollars. You can get reimbursed, and eventually you're going to get reimbursed from Medicaid. I know that's confusing, but that's where it is. So it is, and the PEF update is in progress. And while we're on the subject of the PEF, a lot of health departments have not spent, like right now you should be at about 65% of your allocation or more. Many of you are not. We recognize that your family planning clients' numbers have decreased, but we're really curious as to if you're coding correctly. You know, prior to July 1st, it didn't really matter because you were going to get you were going to get 802 money, and you hoped it would cover at least a portion of your family planning visits. But now you're going to get paid per what you do for your clients. And I'm not saying you need to add things on. I'm just saying that you need to make sure you're checking off everything on your PEF that you've done for your client. Also, make sure your ICD-10 codes are correct. Make sure that your family planning code is there. And so when you have a male patient that comes in for STDs because he's got some kind of a discharge or whatever, he can be a family planning patient, and because you will not get reimbursed for your STD codes, your STD testing and STDs. They don't have any money. All you have to do is say to him and document, what are you doing to prevent pregnancy with your partner? Once you ask that question and document that answer, no matter what the answer is, and chart a method and check off a method on the PEF, his primary code, his ICD code will still be STD. But then if you'll code in family planning as your second ICD code, he then becomes an 802 cost center, and you can get reimbursed for those STD charges. And that's not happening like it should. And I know y'all see a lot more male patients for STDs than what we're seeing on our FPAR report. So make sure you're doing that coding correctly, because it means money, and it means that you get more money. And so, you know, consider that as you go. And if you have questions after this, either we can answer them here or we can answer them through email. Just email me with any questions or concerns. But I'm asking people to go back and look at their PEFs. Somebody have a question?
Yes.
Okay.
So before ICD-10, we did that, I think, pretty consistently, and I'm almost positive we used the V2509. So we would have like the STD code as a primary, and then our secondary was V2509.
Uh-huh.
So will you tell us which code you want us using in that secondary space? Because there's so many, I don't know that we're sure which one to use.
I need to check on it. I'm not sure what it is, but I will email that. When I email my presentation out to everybody, I'll email what the secondary ICD-10 code should be for your STD patients. Do you have another one? Okay.
No, that was it. Thanks.
Okay, thank you. So I'll mail that out to you because I'm not really, off the top of my head, I don't know what it is. Okay, so make sure you're coding correctly. Don't forget your STD clients. The last thing I want to talk to you about is we are writing our grant, our continuation grant for our Title X funds. And we sent out a couple of things. We sent out a clinic hours, clinic sites, hours, and services. We've heard a lot from most of you, but we still have 26 health departments or districts that need to respond to us. I have to send that into OPA, and I need it now. So if you've not, even if your clinic sites haven't changed and you thought, well, they haven't changed, so I'm not responding, please email me or Tori Amberg. I'll give you her email address in a second and say, nothing changed, okay? That's all you have to say, but make sure you've let us know because we have to update that list both on the OPA website and we have to add those to our grant. And believe it or not, they read that with a microscope. I mean, they are very intense about that. And so make sure you are, if you haven't sent me that, please do so. If you say, I don't know if I sent it or not, send it again because we've got to have it, and I really need it by Friday. I mean, it's time to turn that grant in the next week or two, and that it has a ton of approval channels to go through. So please send those to me by Friday. If not, I'll be calling you on Monday. The other thing is we sent out a SurveyMonkey thing that has all this other stuff that we needed for either FPAR or for the grant that OPA requires that we report on. If you've not completed your SurveyMonkey that Christy Royalty sent out about a month ago or more, probably at least a month ago, please complete that and get that on the SurveyMonkey. If you're thinking, oh, I don't know, just kind of look for an email from either from Joy Hoskins or Christy Royalty about that. And we need that done. And again, we've got 35 counties yet to report. And so please get that done again by Friday or we'll be calling you on Monday because that's information that OPA requires. And again, they look at it under a microscope. And so please report that accurately. And we really do appreciate that. It means more money. We're asking for 5% more again this year. In fact, some of the stuff we're going to do with that is we want to look at the family planning program, do some mapping, and do some strategic planning to increase our numbers. Remember, we've got at least 137,000 women that are underneath the 137% below the federal poverty level that need contraceptives, and we met the needs of 48,000 of those, 49,000 of those last year. So, and some of them are going because of Connect to other places, but we need to be able to show OPA where these women in need are going. So we need that money, and also we're going to be able to get more money out to you to be able to provide those services. Tori's address to send these things to send the clinic hours stuff to is tori.ambergy@ky.gov. Tori is our epidemiologist. She's been on board since December. She's wonderful, and we're so glad to have her. Saddened, though, Christy Royalty, our nurse consultant inspector, some of you have already emailed her and found out that she took another position outside of state government. We miss her desperately, but we love her to death, and so that position is vacant, but will be filled as soon as possible. Meanwhile, if you have any family planning questions, you'll want to ask me, and I will either answer you or find the answer and then answer you. I'm learning quickly about everything. Every day there's something new in family planning. Desk audits. Several people ask about desk audits. They are due by June 30th, and so if you want to go ahead and start trying to do those and send them to me or to Melody Stafford, and we will take care of that. Also, the last thing I want to talk to you about, let me get my paper. Office of Population Affairs, who funds us, has decided, and I'll read this so I get this correctly. Just in the last week or two, they have decided they're going to be collecting data from Title X service sites, which is you all, and like my survey is 12 questions. I'll keep going. on various indicators to measure the sustainability of the Title X service sites. Data obtained through the Sustainability Assessment tool will be used to identify technical assistance and training needs for the Title X sites and grantees. The subjects will be enrollment activities, meaning like in insurance, primary care, electronic health records, quality improvement, and revenue. Your survey is 49 questions. We feel like that's a huge burden to every local health department and clinic. So we are assessing the survey, and what we think we're going to do is we're going to kind of streamline that, and the Division of Women's Health, the Family Planning Program, is going to answer on every clinic, because you've sent us a fair amount of this information, and we know the answers to. So over half, I think Tori and I decided there's about 20 or 25 questions, and that includes your name, your clinic, that kind of thing, that you all are just going to have to answer, that we won't be able to answer for you, but at least it's not 49 questions. I will be sending that out within the next week or so. We have to report everything back to OPA by April 30th. And so we recognize that this is a huge burden, but we don't have a choice. And so we're going to help you out with this as much as possible. So instead of you having to fill out that survey yourself and dig out all that F part, they said it would take the average of 10 minutes per question. Well, 490 questions, that's like 8 hours. And so we don't want you to have that burden. We'll take that burden. And but we also have all that, a lot of, like I said, FPAR data, clinic site hours, things like that. So what we will do is we are going to streamline that survey, create a survey monkey that you'll send back to us, and then we will report each individual health department's information to OPA to make that as clean and as painless as possible for you all. And so there is a webinar, an informational webinar on March 21st at 2 o'clock, and I'll send you the link to that from OPA, where they're talking about the sustainability tool. If you want to get on there and listen to them, just realize that as they're saying, you got to tell us this, 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 and this, a lot of that we're going to answer for you, and to help you not have to have such a burden. And but meanwhile, I'll be communicating a lot through the month about that, and making sure you all are getting your stuff into us so we can get it onto through their online survey. And so please, we ask that you cooperate with us so we can get this done. And I again, I apologize to be, don't kill the messenger, because it wasn't my idea. But we do have to do it. We have to be compliant. Okay, questions? Be sure to email me if something comes up and you just say, hey, I have a question about this, or I have an idea about sustaining family planning. Please let me know. And thank you for listening, and have a great day.
Thank you so much, Benita. That's a lot of great information for our family planning programs. We appreciate that update. I understand that many of you are having technical difficulties still with slides sticking and that kind of thing. I apologize for that. We have contacted COT. Apparently, statewide, there are major internet problems. Everything is running very slowly. They're working on it, but we all know how that goes. Again, I apologize for the inconvenience. Bear with us. You will receive all of these slides by email when the presentations are over. We're going to take a 15-minute break now, so let's be back at a couple minutes after 11. Okay, thank you all.
Hey, honey, how are you?
It's like the old days.
I'm
lost
telling
at DPA. Yeah.
All right, welcome back. We are very pleased to have Dr. Elizabeth Amin with us today. She is a board-certified radiologist. She's retired from clinical practice now, but she continues to serve as the chairperson of the Breast Cancer Advisory Committee. During her career, Dr. Amin has served in many roles. A few of those are the chief of radiology at the VA in Louisville. She's also faculty in the Department of Radiology at U of L. She has worked in private practice, and she created a new breast imaging and diagnostic center at the Norton Hospital Pavilion in Louisville. We are so pleased to have her today. She has a great presentation for us on dense breast tissue. You have received an email earlier this week with her presentation notes, so hopefully that will help you follow along. Luckily for us, she has a very low-tech presentation. So welcome to Dr. Amin. Thank you so much for being here.
Thank you very much, Lydia. I appreciate that. Whoops. And this is low-tech. I can't see any of the audience. I will try to speak into the microphone and look at the camera. Also, since I don't have slides, the pieces of paper I have in my hand are simply the same document that I have sent to you. And so literally you can follow along. And I may just ask Libby, do we take questions at the end?
We will, yes.
Okay. So we will take questions at the end. If anything seems to be rushed, or if I seem to have skipped over anything that you have further questions on, that will be the time to wrap it all up. So the title of my talk is simply breast density, or dense breast tissue. And what is this, and why is it important? And hopefully I will lead you to understand that during the next 40 minutes or so. During my talk, I will use the terms dense breast tissue, breast density interchangeably. And also, I may point out occasionally during my talk that the material that I'm covering is specific to women who are at average risk for breast cancer, not women with family histories, with BRCA1 or 2 or other genetic modifications, nor is it pertinent to women who have a prior personal history of breast cancer. So if you'll make a mental note of those conditions, then we'll stay in sync. So then what is breast density? Breast density is just a mammographic term. As long as we've been doing mammograms, we've been looking at the breast tissue and we've been saying, oh, that's easy to read, that's all fat, oh, that's hard to read, that's dense tissue. And I would like to give you some idea of how we categorize this and how, as mammographers, we use this. Many of you may know that in 1999, a federal law was enacted which was called the Mammography Quality Standards Act. We refer to it as MQSA, and that law is still active. The governing body that maintains compliance for breast centers under that law is the American College of Radiology. And the law was set up to make sure that all breast imaging centers had proper equipment, properly calibrated to perform mammograms, that the technologists were properly educated in performing mammograms, and that the radiologists were skilled and well educated in interpreting those mammograms. So the MQSA is a federal law that is still on the books, and every breast imaging center has to maintain compliance, and I believe that that is still a 3-year cycle, as it was all my years in clinical practice. There is no mandate within the MQSA law as to how the mammography report should be generated, but over the years, since 1999, there has been a consensus amongst breast imaging experts that a certain standardization of terms would be necessary. And so shortly after the law was enacted, we developed, through the ACR and breast imaging specialists, a system of reporting mammogram findings, putting data into systems and so on, and it's simply referred to as BIRADS, Breast Imaging Reporting and Data Systems. BIRADS covers every aspect of mammography reporting, but there's one small section that is specific to breast density. And here I have on my high-tech whiteboard just a simple outline of the categorization under BIRADS. Barrett's classification has 4 different categories, simply referring to the density of the tissue on the mammogram. And I'm sure most of you, or at least many of you, have had your own mammograms performed, and you've probably looked at other people's mammograms. So a Barrett's category 1 is verbally described as almost entirely fatty tissue. Normally on the mammogram that would be a black background, just a little sprinkle of ductal tissue behind the nipple. A Barrett's category 2 is scattered fibroglandular density. So the density might be centered on the nipple, it could be centered up toward the shoulder area, but it's just scattered through the otherwise fatty tissue. Barrett's category 3 is heterogeneously dense breast tissue. Again, it may be centered on the nipple, it may be scattered through the breast, but it's somewhat denser, and we refer to that as heterogeneously dense. And then Barrett's category 4 is very dense breast tissue. In your handout, you will note that I assigned percentages alongside the Barrett's numbers, and then I put in brackets underneath my percentages. That was what I used in clinical practice to try and assess the amount of denser tissue on the mammograms. It gave me a sort of baseline of my own, so that when I would repeatedly review mammograms on a number of patients, on different patients, I knew in my head how I was identifying the level of density of those tissues. It is important for you all to know that that's all the Barrett's classification is. It is the visual impression of the radiologist looking at the mammograms and then saying, okay, the 1 says this, the 2 says this, the 3 says this, the 4 says this, I'll make it a 3. In my interaction with many skilled mammographers, their assessment of the 2, the 3, the 4 might be somewhat different from mine. There was not really a consensus, but there was a tendency to move toward, 25 percentages. So category 1 for some people might be 0 to 25% of glandular tissue. Category 2, 25 to 50%. Category 3, 50 to 75. Category 4, 75 and over. And that's somewhat different from my personal numbers on the handout. I cite this not to indicate that we're also egotistical, that we have to have our own numbers. I cite it simply so that you know there isn't a mathematical standard, a technical standard, a number, or a benchmark against which, at this point in time, a mammogram and the density on that mammogram can be measured. It is subjective, based on the radiologist's feelings, or well, not feelings, but visual clinical assessment of the images. And I want you to bear this in mind as we move through this, because the bigger question is, why has this concept of breast tissue density become important? We've always known, however we've done the mammograms, whatever the technology was in use at the time, that denser breast tissue hides breast cancer, or has the potential for hiding breast cancer. If you have cancer associated with calcifications, then it's easier to see the calcifications on the dense tissue, not than on the fatty breast tissue, but as compared with a non-calcified cancer. And so we say that the sensitivity and specificity of mammography is lower as the dense tissue increases in the breast. Simple terms again, dense tissue can hide breast cancer. So we've always known that, and we've always been at pains to do our best with women with dense tissue. What has more recently become apparent, and again, this is a situation that has sort of waxed and waned over the years, denser tissue is probably an independent risk factor for breast cancer itself. And again, I'm just talking about those of us who are at average risk for breast cancer. So here now we have a situation which becomes rather concerning. It's certainly important, and it's important for women when they receive their mammography letter, because part of the MQSA regulation was that even though there was no specific wording required in mammography reports, it was determined and it was placed into that law that a woman should always receive a letter or notification of her mammography result in language that she could understand. And so for years and years and years, the letter would come, hopefully would say, we're glad to tell you that your mammogram is normal. In a lady of your age, we recommend your next mammogram in 1, 2, or whatever number of years, etc. Or the alternative would be, we're sorry to have to tell you that there is a finding on your mammogram which needs further evaluation. Most of the time these findings are not cancerous, but we will need to do additional imaging to help determine this further, and someone will talk to you when you come for the additional imaging and help you understand what is going on here. So those were basically the two types of letters that would go out. And in my clinical practice, there was no mention of breast density on the patient letters. It wasn't a requirement. It was an observation we made on the mammograms. It was part of the mammography report to the physician, but it was never included in the patient letter because the information didn't help the patient in any sort of way. And I'll try to explain that. It sounds a little counterintuitive, but I'll try to explain that as I go through this. So, you know, questions that come up, okay, women have dense breast tissue. We've asked these over the years. Is there any way we can predict who those women are? Maybe we could do their mammograms a little bit differently. Maybe, you know, it might be necessary to do more views for a screening mammogram than on a woman with fatty breast tissue. Well, the answer is that there's really no way to predict who is going to have dense breast tissue. There are some sort of broad generalizations, and I've noted those in my handout. In general terms, the younger the patient, the denser the breast tissue. In general terms, the lower the BMI, the denser the breast tissue. So these tall, slender, muscular, athletic gals who never gain an ounce of weight during their lifetime, yeah, they may tend to have denser breast tissue. And older women who continue to use hormone replacement therapy after menopause, their breast tissue will remain dense. Sometimes it will increase in density, but it won't be very different from the density that has been evident on their mammograms through the earlier years of screening. So we got those broad categories. Again, not everything is quite so straightforward, and over the years, as studies have been done for a number of different reasons, it's become apparent that South and East Asian women who tend to have denser breast tissue, age for age and life stage for life stage, have lower incidence of breast cancer in those populations. So that sort of turns things upside down a little bit. In addition, if we are looking simply at the size of the breast, that is not an indicator as to how much dense tissue is going to be present. I have known many ladies during my practice life with double D cup size breasts and larger, and the density of their tissue extended from the nipple to the chest wall, and it was difficult to read those mammograms, no question about that. And then, you know, the other side of the coin, if we're focusing all our attention on women with dense tissue, we mustn't forget that a woman with a completely fatty replaced breast can go from one screening mammogram that is normal to having a cancer detected on her next screening mammogram. So, you know, we're all women, we're all at risk because we have breasts, we're all in this together. So that is a little bit now of the importance of breast density, its possible implication, and you're probably beginning to sense a little bit of confusion here, or some questions are arising in your mind. How is it in the last few years that women and their healthcare providers are learning so much about breast density? I can't answer that question. I don't know. I became aware of it after I left clinical practice. I was still a mammography reviewer, and I started to ask some questions as well. It is very possible that as the years went on in the early 2000s and so on, more and more mammography reports were being generated using computer software, and that computer software was sort of loosely based on BI-RADS. So terms would come up that would be appropriate for the physician's report, and a term such as breast density might also find its way into the patient's report. And that is not necessarily a bad thing, except that that poor woman was not told what it might mean and what she needed to do about it. So I don't quite know why in the late 2000s and early 2100s there was this very public discussion of breast density in newspapers, on television, on talk shows, and so on. I just don't know the origin of that. What has happened, however, since that did become public knowledge is that certain states have decided to take matters into their own hands and have created state laws. This has nothing to do with MQSA. MQSA, ACR, Society of Breast Imaging, does not take a stand on whether or not this is a good or a bad thing. But in 2009, the state of Connecticut was the first to create the law that says, you are a woman receiving mammography studies in our state and you have a normal screening mammogram. In the letter that you receive explaining the results of your mammogram, there must also be a paragraph which explains what may be the situation if you have dense tissue. Now, you know, we're headed into major confusion here. I do have a couple of samples of different state letters. I'd be glad to share those, read them out to you if there are any questions concerning that later on, but I'm not going to do that at this point in time. So here now you have a state that says, okay, you get your mammogram report. It needs to tell you, A, if it's normal or abnormal, and then B, if you have dense tissue. And then there's a sort of bland paragraph that says a little bit about dense breast tissue. It may be an increased risk for the development of breast cancer, and talk to your doctor about it. So here the woman is confused. For the last 5 or 6 years, all she ever got in the mail was a normal letter. And now she's being told she has dense tissue. She goes to her gynecologist, her internist, maybe her dermatologist, and the doctor said, I have no idea what they're talking about. But if there's any problem, we're going to get you some more tests. Isn't that what tends to happen? And so the next issue in terms of breast density and its implication for possible increased risk for breast cancer is whether and when and how additional screening tests should be done. I'm going to leave that discussion just a little bit to one side for the next few minutes while we go back and recap some of this information. What I said earlier was, assessing breast density is a subjective, hopefully good clinical assessment on my part and on the part of mammography reviewers, but my subjective impression is not the same necessarily as other subjective impressions, as I mentioned earlier on. And it's true that, you know, if somebody faced me with 100 screening mammograms that I had read at one point, and then 6 months later presented that 100 in different order, and so on, I might change a 2 to a 3 or a 3 to a 4 or something like that. So we're talking about breast density, which is sort of shifting sand. The first question I asked myself, or one of the first questions I asked myself when I became aware of this is, you know, is there going to be a technical component that we can build into the mammography system that will enable a density number to be placed on that lady's mammogram? Well, the answer to that question is no, with the exception of a couple of experimental situations. And I was able to find a report of a study of 2,000 sets of mammograms. I've cited it in my presentation, and I'll just go through that a little bit with you and tell you what you know, the future may be in that regard. So between 2006 and 2012, we had basically moved into the era of digital mammography. The old film screen mammograms, which used to be very good, have largely been replaced, not entirely. But once you move into digital imaging, you can insert computer programs into the systems that actually perform the mammograms. And so in 2006, between 2006 and 2012, 2,000 women were identified who developed breast cancer during that period of time. These women were patients at one of the 3 Mayo Clinic centers or one of 4 university-affiliated breast centers in the San Francisco area. So this was a collaborative study. The purpose of the study was as follows. Each of these women identified as developing breast cancer from 2006 to 2012 had had a previous screening mammogram that was normal. It could have been 6 months before the cancer was detected. It could have been 12 months before. It could have been 18 months before. Whichever screening mammogram, whichever normal screening mammogram preceded the identification of cancer in those women was selected for review. So you have 2,000 sets of normal screening mammograms. And the review purpose was to see how the density was assigned to those mammograms, obviously to see if those women who developed breast cancer during the test period had significantly higher levels or higher amounts, if you like, of dense breast tissue than those who didn't develop breast cancer. And this was done by dividing those 2,000 sets of mammograms into 3 groupings. There were 2 experimental programs, 2 different vendors, which were built into 2 of the types of mammography units. I'm not going into the technical details. I'm not sure I could explain the actual technical details. The way the density was assigned by these programs was just different in the 2 systems, and they were experimental. And then the third group was the standard visual assessment by a skilled mammographer in assigning the BI-RADS classification. So what was found was between the 2 groups of mammograms that were assessed by the software programs, there was a density number, if you like, that was comparable, mammogram for mammogram, in those 2 groups. So that number would then be translated into a BI-RADS 1, 2, 3, or 4. When you went to the third group of mammograms that had been reviewed by the mammographers and assigned based on visual assessment, then you could tell that for a similar dense breast, the number assigned by the radiologist was higher than the number assigned by either of those computer programs. So we tend to make a higher assessment just looking visually at the mammograms than the built-in computer programs were doing. So, there's a lot of way to go here. In theory, it gives me optimism that there will be software programs that can be used during the performance of the mammogram or during the interpretation of the mammogram that might assign some sort of true number that's based on the technical evaluation of the tissue that's being imaged. But I don't know how it would happen. One of the systems that is available, one of the computer programs available experimentally at the moment, is based on an entire volume of the breast and then assesses a density that takes into consideration the entire volume of the breast. So, there's a measurement of the thickness of the breast tissue as it's compressed. We've all had that nice experience. And that's built in. And then the other system, as best I can tell, and I certainly am not here to give you the absolute truth on that, but picks up certain points in the breast tissue and assigns a number based on the density. I don't know, for instance, whether one would pick 5 points in the breast on the mammogram on each view and do an average, or whether you would pick 5 points in various areas of the breast and go with the densest or the highest number for the greatest density. I really am not sure how that will work out, if it can be worked out, and so on and so forth. But I think as caregivers, you're beginning to see the picture here. We have cohorts of women being told they have dense breast tissue, and maybe you're at higher risk for breast cancer for that reason. But sorry, we're not really sure what we can do about this. I mean, just imagine the frustration. So since 2009, when Connecticut enacted its first mammography density awareness law, 23 states followed suit. As of January this year, there were 24 states. Kentucky is not one of those states, but there were 24 states which required that a woman's letter include notification of her density. Out of those 24 states, 4, and Connecticut is one of the 4, have mandated that health insurance carriers within the state of Connecticut, or within, I'm not sure which the other 3 states are, I haven't been able to identify that at this point in time, but the state where the mandate is for the insurance carriers to cover the next screening, let me backtrack a minute, I'm getting a little garbled here. 4 states said that if a woman receives a mammogram report indicating she has some sort of density, those 4 states said, okay, now the insurers have to pay for whatever next screening, additional screening test is required. And Connecticut was one of those states that was the first to do that. So if you're a woman living in one of those states, then obviously you're going to have additional testing. And as I'm going to say in just a few minutes, that is going to lead to additional problems, very likely. If you're not living in one of those states, then you might feel, if you're across the border from one of those states and your best friend is getting all this taken care of and you're not, you're beginning to feel, I'm at risk here and nobody's helping me and so on and so forth, and I can't afford to do this. And then within states, the insurers may cover their clientele, but what about those people who are not insured? And so the cycle continues. So So one of the things that I have always found during my career is, you know, we all became used to the jokes that would pop up all over the place, how painful having a mammogram is and this sort of thing. And it is important, and it always was important, and I'm not sure if this is really a part of our modern fast life track anymore, but we always tried to ensure that our younger premenopausal patients had their mammograms done when their breasts were least dense. And, you know, most women with regular cycles can tell when their breasts are least dense, usually after their menstrual flow has diminished significantly or stopped completely. We used to try and encourage premenopausal women to have their mammograms done at a time when the breast tissue could be compressed without causing them too much discomfort. You know, if that's going to require rescheduling, it's not going to happen, and so on. And so we would let patients know, you know, it's okay to take an analgesic before your mammogram, whatever you would take for your period pain or breast discomfort, and let the technologist know that, you know, your breasts are a little bit sensitive today, and maybe she'll be a little more gentle doing the mammograms. But as we all know who have had mammograms or been involved with the performance of mammograms, that breast tissue has to be compressed. And that's no different nowadays with modern digital mammography than it was with film screen mammography in the very, very early days of the Xerox blue paper mammograms. So those are the issues that surround breast density, and to say that this is currently a hot topic in breast imaging circles is an understatement. And I hope that that has given you some idea of the consternation that is swirling around this topic. I said I'd mention something about the additional screening tests that might be performed when women receive a letter telling them that they've got dense tissue. Those tests would usually be either breast ultrasound or breast MRI. And breast ultrasound is not easy to do. It's what we call operator dependent. The technologists have to have a certain set of skills required to do breast ultrasound, just as an obstetrical technologist needs a certain set of skills to do obstetrical ultrasound. By and large, the ultrasound equipment that people put in their radiology departments right now do have a number of different transducers. So I don't think the equipment as such is a barrier. But to find tiny abnormalities in the breast tissue on ultrasound, you really have to go over every square centimeter of the skin and try and get every cubic centimeter of the breast volume, so the patients are lying this way and that on the ultrasound table, and you have to go very slowly. It's a high-resolution transducer, and you are definitely going to find abnormalities. But the vast majority of these will not be cancers. The best way for a breast imager like myself to get on top of breast ultrasound was always to at least be in the room with the technologist while the study was being performed, or in many high-tech breast centers, there were enough faculty, enough staff that the radiologist, him or herself, did the ultrasound themselves. So it's operator dependent, and it finds a lot of abnormalities that are of no consequence but could lead to anxiety and unnecessary biopsies. And in my handout, I refer to an Annals of Internal Medicine review article, a big review article, and I will quote one line from their assessment. In additional ultrasound screening exams that were performed on women just because they had dense breast tissue, more than 90% of those positive secondary test results were false positives. And oftentimes you can't find that out unless you do a biopsy. And they also made a statement because a few women opted for breast MRI, and there was an additional statement that said, in additional MRI screening exams, 66 to 97% of the positive secondary screenings were false positives. But that review also stated very clearly that they were talking about maybe 6 or 7 MRI studies. So that's not statistically significant. So ultrasound has been the way that many of these women have decided to go. And, you know, this is why critics of mammography screening and so on, even nowadays are heard to say, well, you know, you do all these tests, all you find is nothing that is worrisome. These women are put in states of anxiety. They have to travel a long way because the mammography facility does not do the breast ultrasound, etc. They're put to additional costs, all because breast images don't know what they're talking about, sort of thing. So we've sort of lived through that. So that sort of tells you the predicament that everybody is in at this point in time. Just one quick word with reference to breast MRI. Some of you may know that if a woman does have a family history of breast cancer, has a genetic mutation, or certainly has a history of a previous breast cancer herself, then we are now doing breast MRI almost routinely. As I said, that is not the focus of this particular presentation today. In terms of recommendations from medical organizations, the American College of Radiology, the Society of Breast Imaging, I think the Organization of Obstetrician Gynecologists, and I think internal medicine also, simply state that, okay, yes, this is a description of your mammogram, the tissue is dense, you should talk to your doctor about it, but don't panic, and so on and so forth. And that's not always the most reassuring way to talk to patients. So I thank you for your time, and I'll be glad to entertain questions. But I just wanted to emphasize how important this is. This is my trusty blue journal. It's the Journal of the American College of Radiology. This is the March edition. It came into my mailbox on Monday afternoon of this week. And right here is an article by a breast specialist whom I know very well, Dr. Birdwell, who's now at the Brigham and Women's and Harvard Medical School. And they are trying to generate a training program for their residents and their mammography fellows to help them become more consistent in their assessment of mammographic density as a result of all this public information that people are becoming aware of. So it's a hot topic, and right now I'm not sure in what direction we as the profession will go, and how this will be incorporated as part of a woman's sense of well-being and sort of control over her own health, as opposed to a nasty little itch in the back of her brain that says, oh, maybe. So again, thank you very much for your attention. I hope you were able to see or at least hear me, and if there are questions, I think we can answer those.
Do we have any questions for Dr. Amin? Well, thank you so much for being here today. Breast density is a hot topic, and we appreciate your insight on the topic.
Next, we have Melody Stafford coming. She'll be giving us an update on the Kentucky Women's Cancer Screening Program. She has served as our program director for the last 4 years. Prior to that, Melody was a local health nurse at Three Rivers. And here she comes with her update. She has a PowerPoint presentation, but because of our issues, she's just going to talk through it, and we will email it to you later.
You want me to do that?
Yeah.
Yeah, just to help you do that.
Thanks to Dr. Amin. She does a wonderful job with our breast cancer advisory committee. She's always willing to keep us updated on all kinds of good stuff. So thank you, Dr. Amin, and have a safe drive back.
Well, thank you so much.
I hope everyone is well and has avoided the flu. And I'm asking you today to excuse my mouth, not what's coming out of it, but I've had some dental surgery, so I'm kind of lopsided and whatever, so overlook me if you don't mind. I won't take up your time, which I know you're probably hungry for lunch. I won't take up your time trying to get the PowerPoint out since we've had so many problems with it, but we'll get it to you, we'll email it to you, to the nurse leaders, and I'm sure Joey won't mind doing that. I just want to go over a couple things that we're dealing with the Kentucky Women's Cancer Screening Program. I wanted to remind everybody that we continue the same eligibility that we always have. 21 to 64, we're at or below 250% of the annual federal poverty level, and with no Medicare, Medicaid, or third-party payer. One of the questions that we've had recently is that if a person is eligible for some type of insurance, but they still meet our KWCSP eligibilities, like below 250% of the federal poverty level, can we still get them screened? And the answer is yes. CDC has told us if that person does not have insurance, opts not to get insurance, KWCSP will still, if they're eligible for our services, provide those screening and diagnostic services for that woman. So I just wanted to make sure that you all were aware of that, and that if you have any questions about that, call me, because that is ongoing. Had a call recently within the last few days. Somebody asked about that, and we certainly can pay for those services as long as she's KWCSP eligible.
With no insurance, right?
Right. As long as she doesn't have any insurance. So she may be eligible for insurance, but she doesn't have it. Now, the kicker to that is be sure that you always try to find, after they've seen you or whenever they've seen you, to refer them to and tell them about the insurance programs that are available for them. So you certainly want to encourage them to go get insurance, but we will not turn them away just because they choose not to. The reimbursement, like I said, clinical services for 21 to 64, mammograms for 40 to 64. CDC is still allowing us that at 40 to provide those reimbursed for those mammograms. Pap tests for 21 to 64, and that's also through the family planning program that we are able to reimburse for those pap smears. And diagnostic and case management for any abnormal result in this age group. I had a slide in here about what our numbers were in fiscal year 2015. Historically, our program has paid for screenings for around 20,000 women per year for breast and cervical cancer screening, and we referred approximately 450 of those to the breast and cervical cancer treatment program. Well, in fiscal year 2015, we screened, reimbursed screening for 3,900 women, and 55 women were referred to the BCCTP. So you can see how dramatically, and I talk to you guys all the time, and you all know that our numbers for KWCSP have dropped considerably. But many of these women have got some type of insurance or on Medicaid. But this has led us to look again at our grant. We had some money left over because of, we didn't use it for screenings. And we went to CDC and said, what can we do to improve our numbers? So we started what we call a Pink County Initiative, and I'm sure you all are aware of it, or I hope you are. If you're not, call me, which was giving a $10,000 mini grants to each local health department. And the purpose for those mini grants was for breast and cervical cancer outreach and promote and educate and navigate all women for these services. And again, our emphasis remains on women 250% of the annual poverty level or below with no insurance or third-party payer. And now Rom did a great job. You all know Rom. He's called you many, many a time. But our data manager, Rom, was able to establish a wonderful partnership with Medicaid. And we know that all these women may have insurance, but they're not getting their mammograms. As a matter of fact, in that population, only 28% of the women who are insured or have some type of coverage are Medicaid, under Medicaid, that's all that has received those screenings. So CDC says, okay, let's outreach to all women. You know, we used to use just outreach for our specific population, but now CDC says that we can outreach to all women. So we put out this Pink County Initiative, and we're hoping to increase the mammograms by 50%, or by, ooh, I love that, 50%, that just came out of nowhere, by 10%, and cervical screenings by 5%, and we also want to identify challenges which have prevented these women from receiving breast and cervical cancer screenings and diagnostic services. We are going to take that money, and like I said, we've received a great many. You all responded beautifully to this grant initiative, and there's just been a few that didn't feel like that they wanted to participate, but it's going to be really interesting to watch the numbers. We hope that it is extremely effective because we put this money back into the next year's request. So hopefully we can see some numbers go up from your all's efforts. The thing about this one is pretty easy on the data collection. With KWCSP, we still want you to do the same things, fill out the ACH 58, so forth and so on. But with the Medicaid numbers, we will be collecting the data within the KWCSP staff. So you don't really have to do anything. Rom's going to compile all that information, and we will send it out to you at least on a monthly basis. Our expectations from that grant is just to report your progress as far as what the initiatives that you all have implemented within your counties. You may not be able to get this done by the end of the fiscal year, and you can request an extension. And the only one thing they say is it cannot be used for food, so just keep that in mind. At this point, I had a slide that if you looked at the grant application and the information we sent along with it, it had the state, the geomapping that showed the counties in their different colors of where they were in the screening numbers. And kudos to Marion County, because Marion County was the one that had screened the most, and they were over 40%. So I just wanted to do a shout out as we start this initiative that Marion County, you get a pink certificate of sorts. So one thing that hasn't changed is our wonderful quality of care that the nurses within the local health department have provided to these patients for years. I've had a wonderful opportunity of working in the local health department for 18 years. And I tell you what, I know what type of people that you are. I know many of you all personally, and I know your hearts are with the women that you see in the clinic. But we met every one of the core performance indicators that related to quality of care for the 19th time. And I know you've heard us call a million times and say, how about the MDEs? It's MDEs time. Check this, check that. And we appreciate that so much. But because of your efforts, those quality of care indicators have been met. And I have a slide right after this one that says exactly what those particular things are. And there's 9 indicators that are related to quality of care. That's basically what I have in a nutshell. I didn't want to use the slides and take your time up trying to get it to work when I didn't have as much to talk about. But I want to also thank my staff. There's Rom and Gina Reed, who's our person out in the field in the western part of Kentucky, and Christina Maricini, who is our recruitment coordinator. We are in the process of looking for a couple more people to work not only with clinical services as well as in the field. So that's yet to come. Do you all have any questions at all? This will be a first if you don't ask me something. Okay. Well, give me a call. You know that you can call us at any time, and we'll be glad to address the questions that you have. Thank you. Have a wonderful, wonderful day.
Thank you, Melody. We appreciate you being here. Other questions? No? Okay. Thank you all for being with us today. Remember to go back on train and fill out your evaluations. This update will be archived in the next couple weeks. I'll let you know when it is available for viewing. We'll also email the presentations to you along with the answers to those questions that were raised. I would like to thank Rebel and Joy for their help in planning today's events. Also, a huge thank you to the random people in this building that helped pull off the ITV today. Special thank you to our presenters, Dr. White, Anita, Dr. Amin, and Melody. We appreciate your time and for sharing your expertise with us. Also, thank you to the nurses watching this today. We continue to do some great things for the health of women in Kentucky. So keep doing what you're doing. Let us know if you have questions. Thank you.
All right.
There were quite a few.
Uh-huh.